Shops from Telford and Wrekin End of Life Group. And Kath Mannix has very kindly agreed to come and speak to us this evening. Originally, we were supposed to be meeting in SEC, but obviously for reasons that you can't have hoped to have avoided over the past year, getting to get together was a bit difficult, but Kath very kindly agreed to speak to us virtually. Sometimes introducing these things is really awkward because you really have no idea who the person is that you're talking about. And I get to introduce you to someone who's really special to me, both personally and in my professional career. Kath is one of those people who inspires you to not just be a good doctor and be a good clinician, but just to be a good person. She worked at Marie Curie Hospice in Newcastle, as in not the Newcastle that we know down here in West Midlands and East Midlands, but up in North East, and worked at the Royal Victoria Infirmary as a palliative care consultant. And since then, Kath's become a bit of a media star, writing a book basically, which if you haven't read, I'm jealous, because you get to experience reading those stories for the first time. And I no hesitation on utterly recommending to read this book, whether you're a doctor, nurse, healthcare practitioner, kind of just a person. This is an utterly life-affirming book about how good it is to be alive, but how good death can actually be, and actually how good and positive it can be to actually talk about it. So I'm going to shut up talking and let Kath speak for 15 minutes. So our agreement is we're going to talk for 15 minutes. If you type questions in the side of the screen, and I'll field the questions to Kath as they come along. And then Kath's going to present again for another 15 minutes, then we'll feed questions from there. Apologies already that I cannot hope to cover everybody's questions, but I'll try and capture a flavour of the things that people are saying. So I'm going to shut up and hand over to Kath, and then I'll kind of come in about 15 minutes time, Kath. Once again, thanks so much. I'm really excited to hear what you're going to say.
Well, what a lovely introduction. Thank you so much. And, you know, people contact me privately afterwards. I can give you the dirt. Derek was a fantastic trainee to work with. And this is my second visit to your trust. It's really, really lovely to be back. I'm desperately scanning the icons at the top of my screen because I had a share tray earlier on and it's disappeared. And I want to show you some slides. Hang on while I'm just checking. No, Jill, help, my share tray has disappeared.
You're sharing already, Kath.
Oh, you can see my slides, can you?
Yes.
Oh, okay. I've got a different screen from that. Let me find where those slides must be then. Okay, let me do that. Is a slide opening?
Yeah.
Marvellous. You've all disappeared. That's my palliative care joke, obviously, although ordinarily, of course, the curtains are going in the other direction. I was asked to talk about advanced care planning. What I want to do is to just think about dying and death before I start to talk about advanced care planning. So I want to start with, this is a diagram from a Nuffield Trust report about patient flows in medium-sized hospitals. So this would represent people from across your area pitching up at the front of hospital, either walking themselves in or coming in by ambulance or being referred in by GPs. And it's not about the detail, really. What you can see is that the patient flows through the acute medical unit, ED, the frailty pathway, ambulatory care, and then gradually moving towards discharge or being ward-based, and then eventually everybody is either discharged or on a ward. And it's fascinating because there's obviously a missing outcome here, and this diagram, it wasn't spotted before the publication went out. So we need to think about the fact that death is actually the universal outcome of the human condition, and it will be properly and rightly an outcome of some hospital admissions, and will be properly and rightly the outcome of an episode of care for a person who's being looked after in their home, whether that's a house, whether that's a relative's home, whether that's residential care. And we know that at least 1 person in 3 who's in your hospital now, who came in through the acute take, is in their last year of life. We know that 80% of care home residents are in their last year of life. The difficulty is that we can't work out which is the 1 and which are the 2 of the 3. Although if you do a ward round, I guess you could bet on your hunches and let us know in 12 months' time whether you were right. But I think the take-home message here is that people will die, even if we're trying to stop them from dying. And ordinarily, the only way we will spot it is with the retrospectoscope, which is a special nasal instrument. So if we're thinking about this, then we need to start to think about how are we going to talk to people about dying. How are we in primary care? How are we in secondary care? Going to begin those conversations and then progress them. So this is guidance that was produced by the Royal College of Physicians in 2018. And if you haven't had a chance to look at it, I absolutely recommend it to you. It was updated as we went through COVID, and the equivalent publication through the Royal College of General Practitioners would be the Daffodil Standards, which is GPs in collaboration with Marie Curie working for end-of-life preparation, advanced care planning, and then care standards during end of life. All of this is in the context of the ethics of decision making, and I'm not even going to attempt to discuss medical ethics in front of Derek because that would just be embarrassing. But we know that this last year things have been particularly difficult, and we've had to think about advanced care planning in the round very, very quickly. The notion is that approximately 1% of a practice's list would be not unlikely to die in the next year, and that therefore practices will have a palliative care list that's about 1% of their population. What we know around the country is that the practices that are performing absolutely best are getting to about 60% of that 1%. So only just over half, and most people are somewhere in the 20 and 30%. So because that exercise was so far behind where it was required to be, suddenly we had to move very quickly at the beginning of COVID. And so we know that there's been massive fallout from that. People were coming to hospital, and people who were not in that category of we're expecting them to die in the next 12 months suddenly were so sick that they could die. And we were needing to make decisions at the front of hospital about what might be the ceilings of intervention for this particular person, or ask them what their preferences were about ceilings of intervention. So the Society for Acute Medicine, the Royal College of Physicians, produced guidance about making those decisions, and they also produced specific guidance about people dying from COVID, and they beefed up their ethical advice so that we were helping people to make decisions not at the point of the decision, but actually to do advanced care planning at the front of the hospital. It's been a really difficult time. Everybody did their best. Everybody is really, really tired. We know that mistakes were made. I feel that they were largely honest mistakes. And actually the tone of the CQC report about DNA CPR decisions during COVID takes that same tone, that actually there were examples of regressible practice against a background of people needing to move very quickly and as compassionately as possible. And that there is work to be done, there is no doubt, and it's about advanced care planning. The difficulty that we have is that the patient moves sometimes in a predictable way, but sometimes not at all in a predictable way, between different places, between different care teams, between different settings. And so we've got this challenge of starting a conversation in one part of the system and then maintaining that conversation and keeping the planning up to date as the person moves between different parts of the system. If we're going to be able to deliver the care a person prefers in a crisis, often when they don't feel well enough to tell us what their preferences are, we need to plan ahead, and we is all of us. So whether you're joining us today from primary care or from hospital care, whether you're joining us from social care or health care, whether you're joining us from the hospice, this is about all of us working in teamwork, in concert, to get this right for these individual people. And we have to recognise that it is hard, and we need to think about, well, why is it so hard? So this is my only graph. This is just to prove that I used to be a doctor. I've got a graph. This is life expectancy at birth for the last 170 something years. This is the decennial tables that are produced by the Office for National Statistics. So the next set of 10-year tables is due to be made from the end of this month, from the end of April 2021. So in a year's time, this graph will be updated again. But what we know is through most of the 1800s, life expectancy at birth slightly greater for women than for men, and people lived to be usually into their 40s. And so generations would be living close to each other. People would see dying happening at home. If you were wealthy, you might have a doctor. If you were not wealthy, you would have the usually canny woman who understood how to look after people while they were dying, or look after people while they were in labour, or lay out dead people afterwards. And when my grandmother was born in 1900, life expectancy was just starting to pick upwards. So the first half of the 20th century saw quite an interesting change in life expectancy at birth. And that was really about childhood deaths being reduced as we had better housing, better sanitation, the creeping beginnings of an immunisation programme. But then the bigger change again in the second half of the 20th century was about the health progress. So antibiotics, anaesthetics that were better, that allowed more deep surgery, organ transplantation, organ replacement therapies, intensive care units, better cancer therapies. So we started to be better at stopping people from dying of diseases in the second half of the 20th century. So if we just think about my grandmother, born in 1900, by the time she was in her mid-30s, which was in the mid-1930s, which was a difficult time in Britain, there was a lot of poverty, they lived in the wrong part of Liverpool. By that part of the century, she had already had so far a kind of 19th century experience of looking after her parents when they were dying, having siblings die and being part of their care as one of the older daughters in a family. By her mid-30s, her husband had died of sepsis. One of her children had died of an illness we routinely immunise children against now, diphtheria. And she was widowed with 3 small children and 6 months pregnant. And then between her being 39 and 45, she and her children moved out to live in the countryside. They lived in Colebrookdale, and the remnants of the family now still live in Telford. So feel like I'm kind of coming home. And so she was already almost beyond her life expectancy at birth by the time she was 48 and the National Health Service arrived. Discussing her surprise about things just shy of her 97th birthday, which the mathematicians amongst us will have realised would have been in 1997, having outlived her life expectancy at birth by 2 now. The 2 things that surprised her most, one was that she was still alive and actually relatively robust, just becoming weary with what was to be an undiagnosed colorectal cancer, in fact. But also that her children had no knowledge of what dying was like. They were too young to remember their dad and their brother dying. 2 of them weren't born when their brother died. And there had been no significant family bereavements since then. So in the space of a single generation, which was her children's generation, which is my parents' generation, British people forgot what dying looks like. And because they don't know what they don't know, they replace that with hearsay, they replace it with information they can glean from other places, because as a nation, we've become unfamiliar with death, and we've become unfamiliar with how to recognise it, be companions to it, prepare for it. So we instead have to deal with a whole load of modern death myths. So let's think about the death myths. Well, each of the soaps produces an annual YouTube film. You might know this, with the deaths from this year. And what we know is that each of the soaps now is progressively more deathly, that, you know, Albert Square has become a much more dangerous postcode than it was when EastEnders first started a few generations ago. Usually the deaths are outrageous. A note here for Coronation Street a couple of years ago, doing a really fantastic end-of-life storyline about a young mum dying from cervical cancer. But that's a noble exception. Now, this matters because people take notice of soap operas. In Peru, which I visited for a book festival towards the end of 2019, they were struggling to recruit organ donors in Peru, and the government asked their two most popular soaps to include organ donation stories in their plot lines. And within 6 months of those stories, donation rates, although from a very low baseline, had trebled. So people take notice of what they see on their television screens. So death as entertainment is thriving, whether it's watching death on screen or whether it's frightening ourselves because of silly things about death, because we really like to be entertained. And then, of course, for those of us who don't do either of those things, there's always that well-known medical journal, the Daily Mail. The difficulty about reporting in newspapers is it's unusual for them to make the story up. The problem is the stories that get there. So if you only knew about air travel, what you read in the newspapers, you would never get on a plane. And what's happening about dying and death is that it's the equivalent of the plane crashes that get reported. And perhaps this is our most difficult death myth. The myth that if you die and your heart stops beating, a few quick pumps on your chest by somebody wearing a pair of gloves and you'll be sitting up in a little while drinking a cup of tea. Now, actually, our death myth about CPR is a little bit better in Britain than it is in America. People have looked at the relative recovery rates after CPR in soap operas in the UK and in America. So they have something like a 60 to 70% recovery in USA dramas, and we're much more realistic at being around 45 to 60% in the UK. And of course, the real number is if you happen to collapse next to a first aider who's fully trained in CPR somewhere beside a defibrillator, then you're about 1 in 10 chance of leaving hospital alive. But whether alive is the way you were when you were well before your cardiac arrest is a moot point, and it's maybe twice that if you have an in-hospital cardiac arrest. So we've got this difficulty that if the heart stops first, there's a first aid procedure called CPR, which might keep your tissues sufficiently oxygenated that you don't die before the heart problem can be sorted out, but probably won't. And that is mistaken for a procedure that resurrects you, not when your heart stops first, but when at the end of a dying process, eventually your heart stops last. And we're trying to protect people from unwanted, unnecessary, and completely futile CPR at the end of dying with DNA CPR certification. And then families and the media are misunderstanding that as rationing or ceilings of treatment that are based on age or the fact that you've got an illness rather than on medical prognostication. So the death myths are not helping us in our conversations. And the other problem we have is in recognizing when dying is going to happen. So a lot of you be familiar with these graphs that were published first in the BMJ in the late 1990s of trajectories of dying. So in cancer, we can keep people relatively well until we run out of options. And then there's a relatively predictable trajectory of decline towards the end of life. And that makes it easier to be able to prognosticate and to be able to palliate. But a lot of people are actually suffering from long-term conditions, which is the red dotted line, where actually their quality of life isn't as good as a person who has cancer but who is currently well. But they then have a trajectory that's punctuated by crises. And when each crisis happens, we don't know whether this is the one where we're going to be able to drag them back from the jaws of death or whether this is the time that they're going to die. And then the long-term frailty trajectory, which is just so difficult to call because change is so difficult to notice before the person eventually dies. So we're trying to deliver a service and we're trying to help people to plan ahead in a situation where the public doesn't understand about dying and the government isn't helping us to talk about it. So if we're going to plan ahead, we need to acknowledge disease progression and be able to talk to people about whether treatment is worth it, depending on what the outcome is likely to be and what that outcome means for them and for their values. We need really good, realistic plans of what to do when a person feels less well, because they will dial 999 or they will bring themselves into hospital if there isn't another robust plan in place. And it's no good just the medics knowing the plan. The family needs to know it and to understand it. It works best if it's written jointly with the person and their family. And because it needs to be a plan that's written so that the services that are available to the person where they live are taken into account, almost certainly most detail of out of hours crisis plans need to be written by general practitioners and primary care people who know what we've got. But that doesn't mean that they're the only people who have the conversations. It behoves us in hospital care to discuss the possibility of dying, and for all of us to be able to talk about what will properly happen as somebody's dying, in order that they can realistically decide, well, if that's what's likely to happen, where can I be looked after? Where is a good place for that trajectory to happen? So I'm going to move on to talk about advanced care planning in a bit more detail and helping people to look ahead with hope. But I wonder if we might just pause at that point and see whether anything's come up for discussion or anything anybody wants to say before we go any further.
I'm back. I mean, the main questions have started to come in about advanced care planning. Can I have chair's privilege? Can I just ask you what sounds like a really simple question, but sometimes it's actually quite difficult to articulate? And I think it determines how we do this. Why do you think advanced care planning is a good thing in the first place?
Okay, so I think that if somebody's got a robust set of expectations, then they feel less vulnerable, they feel less afraid, and they know what to do. And that, that works whether you're a person who's planning finding a job, planning going to university, planning how you're going to manage your long-term condition, planning your retirement, and planning the end of your life. If you know where you want to be, if you know that the people around you will honour your wishes as far as those are honourable, then you're going to have a lot less uncertainty to juggle with. And I think it's uncertainty that triggers us into anxiety. Anxiety, I guess, is the thing that we're trying to avoid. So because advanced care planning is so hit and miss, the few studies that we've got of it are of populations where about 4% to 11% of people have some kind of planning in place. And so it's a little bit difficult to comment on the numbers, but those studies seem to show that those people are more likely to spend more time in their preferred place of residence over the last 100 days of life. The difficulty we've got is we've got kind of perverse measures like place of death. And we all know that that can be a kind of last minute panic. So the place of death isn't the preferred place of residence. So I think we need to have better measures, and actually looking at quality of life over the last 100 days of life, place of residence over the last 100 days of life. Those sorts of things are a far better measure than where the person died. We also know that where the bed isn't as important as who the people are around it. So actually, we do need to think about that's part of the planning.
So what I love about what you've articulated there is that advanced care planning is nothing special, because actually advanced care planning is what we do through life.
Yeah.
So actually, why wouldn't we be having this conversation about what your preferences are? Because at the minute, do you want to go to Durham University or Manchester? That's a discussion that I'm having with my family. It's just the circumstances and the kind of things that are around it change rather than the conversation itself. So maybe if we normalise the conversation, and that's what we get in our
I
heads.
absolutely agree with you. And I think that the other thing is that if you come into the conversation saying, oh, there are decisions to be made, then that actually then rakes up the anxiety. Whereas if you come into the conversation saying, okay, so you're trying to choose a university, you're trying to choose a life partner, you're trying to choose what you're going to do after you've retired, what really matters to you? And if we have these as what matters conversations, then we can wrap whatever the decision is around the things that really matter to that person. And it becomes an uplifting conversation about what can we do that satisfies what's really important to you, rather than where do you want to die and I need to fill in this DNA CPR form. So I think this is about conversations. It's not about forms. I think the form should not be in the room during the conversation. And I think it's probably not possible to start to fill in the form until you've had 2, 3, 4 conversations.
You've made me quite nervous about thinking about future life partners. That's the one thing I don't want
Yeah,
to happen.
especially as Mrs. Willis has just joined us. Yes, I noticed.
She's actually listening in on her way back from work, so I'll be in trouble when she gets back. Kath, lots of the questions are actually around advanced care planning, so I don't really want to steal your thunder. So
Right,
you
let's
carry
move
on,
on.
go
Let's
on to
move on.
advanced care planning, and then we'll field all those at the end.
Okay, so I've badged this about looking ahead with hope because I do think it's about honouring what really matters to people. So, what's it about? It's about clarifying people's expectations so that then, if we ask them what their preferences are, they can think about what their preferences are under those circumstances. So, if you're going to be paraplegic, is it realistic to carry on trying to live in your house where your bedroom is upstairs and the toilet is downstairs and the stairs change directions 4 times between those 2 levels? If it's likely that you're going to need to see the doctor quite frequently during this unusual illness you've got, do you really want to go and live on that farmhouse on the moors with your daughter with her 6 children under the age of 8, where you have to share a bedroom with one of them? So thinking about what the illness is, what it's likely to do, what really matters, and how can we help to support you enables the person now to be joining us in that conversation as a peer. So this is something we're doing with somebody, not doing to them. And what we're trying to do is get the healthcare bits of that adjusted. And that's a little bit of the future plan for that person. We are bit part players in what is a huge, important social, personal journey. And what we're trying to do is keep the person feeling well enough that they can enjoy being who they are amongst their friends and their family for as long as possible. So when we're trying to make responses future healthcare events respect this person's wishes, we're not just talking about what the statutory services know, what the out of hours services know. We're talking about what the family and friends know, because if this person suddenly becomes too unwell to tell everybody, the next level of people out, family, friends, the visiting domiciliary social carers, the care home staff, those people also need to know what is the plan, what are the values we're working to here. So we've got future responses that are, for some people, step up and do everything very quickly. So if you've got somebody who's an arteriopath, who's had horrible pain in their leg that's been managed by a recent arterial graft, and their ischemic pain is so much better, and that is a triumph of modern surgery, then if the pain comes back or if the foot goes white, then that's not a take a couple of paracetamols and see how you go situation. It's not a we'll take you along to the local emergency department situation. That is blue light to the vascular surgery team, which for a lot of places is actually a tertiary centre. So that's a step up and escalate plan to do as quickly as possible. Whereas for other people, it might be that if conditions change and we're not quite sure how things will change, then at that point, what we'll do is we'll all just take a step back. We won't rush to hospital. We'll just think about what are the options now and evaluate what to do next. And sometimes it's clear that what we're talking about is end of life care and palliation, and that is a stepping up response. Palliation is never less. It might be less intervention, but it's not less care. So how are we going to get into those conversations? Well, usually these are patients who we're seeing for something. So while we're seeing them, we have an opportunity to say, as well as what we usually talk about, or as well as the thing that you're here to talk about today, I would like to start to talk about what you'd like your care to be like in the future. We don't have a huge amount of time in an outpatient clinic. We don't have a huge amount of time on a ward round, and we don't have a huge amount of time in a GP consultation. So I'm not suggesting that we have the conversation. I'm suggesting that we invite somebody into the conversation. We ask them some questions that they can go away and think about, and then we come back to pick up the conversation. And these are the sorts of things that we can ask people to think about, whether they have concerns about what might happen to their health in the future. Most people are pretty sharp. They know things aren't good, and they have concerns that they don't feel they can air unless we give them an opportunity. One of my most helpful questions is to say, what I'd really like to understand is, what's your best hope and what's your worst dread about what might happen in the future? Because what I'd like to do is work with you and all of the other doctors and nurses and everybody else who works with you to tailor a plan that tries to make what happens in the future as much like your best hope and the least like your worst dread as we can possibly make it. And what do you think we need to do to make sure that things turn out more like your best hope and less like your worst dread? People will have great ideas about this. So that is the start of a process, because advanced care planning is very rarely an event. Front of house during COVID, it became an event, but usually there should be a series of conversations. And people can usually tell us very clearly whether their goal, for example, is to live as long as possible or to live as comfortably as possible. And those goals might change and they might swap in both directions a number of times over the last part of somebody's life. So if your goal is to live as long as possible, what are the milestones you want to achieve? And let's think about them. Why are they important? So you, with your absolutely dreadful COPD, now on oxygen at home, want to try to get to your granddaughter's wedding in Australia next year. Well, actually, how realistic is that? Are you going to be well enough to fly? What's the oxygen pressure at 32,000 feet? What's the backup plan? If you can't get to the wedding, what can you do to celebrate the joy of it? What wedding present have you planned? Can you join her when she's shopping for her wedding dress on a video call? Can you envisage a time or circumstances that could change in a way that might change your goal to live as long as possible? And can we discuss that again in the future? And help me to understand where you set the balance between the length of life expectancy you want and the comfort and quality of your living. What about somebody who wants to live as comfortably as possible? Well, we want to know what good quality of life means for that person and whether there's anything that needs tweaking now to get them closer to a quality of life that they will appreciate. And can they envisage circumstances when those goals might change? So your lady who didn't get to the wedding in Australia, but the wedding was lovely and she attended it by Skype and it was fantastic. And she slept for 3 days afterwards. And then she said, Doc, do you know what? I've got to that wedding now. We can stop all those difficult treatments. Now for me, it's just about being comfortable. And then 3 months later, she says, you'll never guess what? My granddaughter's pregnant. You've got to keep me alive for another year, Doc, because I need to see this baby. So these goals change and we need to be able to change backwards and forwards with them, always asking people where they set that balance between length of life and comfort of living. And then eventually we're allowed to fill in the paperwork or the on-screen work. So your users of respect locally, but around the country, there are a variety of models. But the really important thing is that when you fill the form in, to fill it in absolutely completely really helps the person who is making the do not attempt CPR call for real in the future on the basis of that paperwork. And when it's challenged by a family member, to be able to look at it and say, actually, on this date, this decision was discussed with your mum, who we're talking about now, and also with another relative whose name is X, who sounds like they're probably your brother, are they? I'm really sorry that you didn't know, but it was discussed with your family. So help us to help each other by filling the forms in properly. But not just what not to do. Do not escalate to hospital. Do not put me on a ventilator. Do not attempt CPR. I don't want blood products. I'm vegan. Don't give me anything that's got animal things in it. But also what to do. In an anticipated emergency, what to do. And then everybody needs to know, patient, first line supporters. You've all met the daughter from Australia who comes in and starts yelling that we're not doing this, that and the other, because the family haven't wanted to worry the daughter in Australia by explaining the minutiae of the arrangements that have been in place. And now she wants to know why you're not doing these things for her parent. And then the usual medical advisors. So who's involved in this person's care? We should be co-writing these plans. Primary care team, long-term conditions team, or the cancer team, mental health team if they're involved, psychogeriatrics team if the person has dementia, palliative care team. So whoever is involved, we need to comment on drafts of the document before it's completed. And then we need out of hours responders to know that the documents are in place and how they can see them if they get called in an emergency. You know about best interest decision making and putting the Mental Capacity Act into action. We need to make sure we've got the right decision maker. So if the person has given lasting power of attorney for health and welfare, including life-sustaining decisions to someone or several people, then they are the decision maker. They are allowed to turn down treatment on that person's behalf. They are not allowed to demand treatment any more than we as individuals can demand treatment for ourselves. But if there isn't somebody with powers of attorney, then it's the prescriber of the medical intervention or the facilitator of a social intervention who is the decision maker. And the process is about ascertaining the least restrictive decision that actually matches best what we think the person would choose. And so there may be ways of finding out what the person would choose, even if they can't have capacity. They may be awake enough to have an opinion. They may have an ADRT that isn't applicable, even though it's completely valid, but it tells us a lot about their decision making, what they valued. It may be that their family can tell us, we discussed this and this is what mum always said. It may be care staff who've got to know this person very well over the last year or so, who are very clear about what the person wanted or didn't want. And then we have to help each other. So we have to think about when the communications move from the hospital out into practice, what are we telling GPs? GPs get a huge volume of letters from hospitals every day. How can they go through it all to pick out that 1%? Maybe we need to be telling people this person now is so sick that I wouldn't be surprised if they died in the next year, and therefore they are eligible to be on your palliative care register. And I've started the process by, I've said to them, we need some conversations about their preferences in the future. So yes, I've told them that we need to start planning. No, I haven't started the conversation. And yes, I've phoned the GP or I've put in the GP letter that that needs to happen. And then how far through that process are we? Have we thought about future crises? Is there a plan for emergencies? Because there's not enough room on a respect form for a proper plan for emergencies. Has the person written an advance decision to refuse treatment? Do they have a lasting power of attorney? Is the resuscitation status clear? Where are the forms, etc., etc.? Why can't we put something like this at the bottom of all of our letters? And then it's either crossed out because it's not appropriate for this person, or it's actually part of the communication with every GP. Because what we need to be able to do is talk to people about dying. And my campaign is about helping people to understand that dying is a recognizable process, like giving birth is. It's got clear stages, it's got a predictable progression, and we can recognize it, we can describe it to people. So this is how I describe it to people. What we find is that towards the end of people's lives, it doesn't really matter what the illnesses they've got. Towards the very end of their lives, the pathway is very similar, and it's mainly that people are very tired. And you may already be noticing that you need more sleep than you used to need. And people will say, yes, doc, I do. Right. So you're following the normal pattern then. So as time goes by, what we find is that people need more sleep and they're awake less. But when they're awake, you know, your illness hasn't affected your mind or your brain. So people are their normal selves. This is a slightly different conversation if you're working with people who have a developing cognitive defect. As time goes by, we find people are asleep more and awake less, and your family will find that you're more sleepy. And one of the things we know is that people dip in and out of unconsciousness. until eventually they're unconscious all the time. We know people don't notice themselves losing consciousness. They wake up after a lovely sleep. They tell us they've slept really well, but we know we couldn't wake them up when a visitor came, or we couldn't wake them up when it was medicine time. So they haven't noticed, but we have. And that might mean that for those drugs that you take for your breathlessness, or for those drugs that you take to keep your pain away, that would be a time when we would know we mightn't be able to rely on you swallowing things at the right time anymore. And we would switch the way we give you those medicines then, probably put them into a little pump so that you get the right dose over 24 hours and that breathlessness doesn't come back to bother you, or that pain doesn't come back to bother you. And we can talk about that closer to the time. So what we're really seeing towards the very end of people's lives, what your family will see if they're in the room with you, is a person who is just unconscious. And as we become more deeply unconscious, our breathing changes, runs in just automatic cycles. Sometimes it's very deep and it can sound a little bit snory. People sometimes breathe through their voice box and they make a funny noise as they breathe out. So if your family are worried, we'll come and check, because they might think it's groaning, but actually almost always it's a sign to us that the person is deeply unconscious and not uncomfortable. And sometimes the breathing is faster, sometimes it's slower, sometimes it's deeper, sometimes it's shallower, and it moves backwards and forwards between those patterns. So if a time came where, for example, it was quite fast but quite shallow, if your family didn't know, they might think that that meant you were breathless or panting. And again, we might need to check, but almost always it's just another sign of being deeply unconscious with automatic breathing taking over. And towards the very end of somebody's life, we start to see their breathing slow down, and there are pauses, and sometimes there are quite long pauses, but the person is still deeply unconscious, not distressed, and after one of those out breaths, there just won't be another in breath. It's as simple and as gentle as that. So if your family are in the room with you, we can't stop it from being sad for them. If they love you and it's goodbye, that's very sad. But they're not going to see something that's going to frighten them or traumatize them. You won't be conscious, and they can be around you and be your companions. Is that what you were expecting? It's never what people were expecting. Almost always what happens is there's then a pause, and then they say, can you tell my family that? Will you tell my husband that? Will you tell my kids that? Because actually, people are expecting EastEnders, people are expecting Hollywood, people are expecting Daily Mail. So we need to be able to describe dying to people so that we can behave like midwives. We tell them what to expect in advance, and then as it's starting to happen, what we do is describe it again to remind everybody that we've already talked about this. So when people are coming into hospital in crisis, or when we're doing a home visit during a crisis, what we're trying to do is work out what's going on, what's making this person so sick, and is there a component of this that's reversible, and how reversible would that be? Because the bottom line here is there an outcome for this person that is worse than death? If I stop them from dying, what do I bring them back to? And so we need to know what the person would want. What do they already know? What are their wishes? What is their preference about life expectancy compared with quality of life? How much disability is this person prepared to tolerate? So that we can make the right decision for this person rather than just a life-saving, but possibly not living-saving medical decision. And it's really helpful if there's an emergency healthcare plan, which we can follow in the community and we can follow in hospital as well. So useful things for us to think about when somebody presents sick enough to die. Is death a possible outcome here? And if it is, even if we're still giving treatments with resuscitative intent, in case this doesn't work, what would dying well look like? So we're talking now about parallel planning, restorative treatment and end-of-life care treatment at the same time. And if we need to offer sedation, perhaps because we want somebody to be able to lie still in a scanner, to just remember this might be the last time this person is conscious. And that pause to say goodbye, that pause to have a cuddle with your spouse, that pause that our ambulance drivers, our paramedics have been offering to families before they've taken somebody away to hospital with COVID, is a really important and precious moment that we mustn't overlook. So the sorts of phrases that might be helpful are to just ask ourselves, is this person sick enough to die? And how do we communicate that to the person and the family? I'm really worried that your dad is so sick now that he might not survive the night. You don't have to thrust D words down somebody's throat, but it has to not be ambiguous. I'm really worried about your dad isn't enough. Your dad's blood pressure is worryingly low, isn't enough. Your dad's kidney failure is getting worse, isn't enough. This is a person now who's so sick that we may not be able to save their life. In case we can't reverse what's happening, in case we can't save your mum's life, what will we wish we'd done tomorrow or the day after or the day after that we could get in place now? And what do you know about dying? What do you think is going to happen? Can I tell you what to expect so that it's not going to boggle your mind and terrify you? So we're back to the beginning, really, aren't we? Death happens, and sometimes we're not trying to stop the death. We're trying to prevent harm and suffering and recognizing that death can be our ally in that. That achieving comfortable dying requires us to be diligent. It deserves our full attention, and then we get out of the way. So the center stage is the person and the people they love, and not us. So we got to be able to see dying as a universal outcome rather than a medical failure, and to recognize that when dying goes badly, often it has been a medical failure. So we're using every deathbed as a learning opportunity for families, so we're explaining what's happening, for us, for our healthcare students. So every death is helpful to us, and we don't waste it, because there is only one chance to get it right. So we need to be proud of discussing it in advance with compassion, and that enables us then to be proud of managing it well. I think that's my last slide, and I can change screens and come back and see you all. Hooray, you're still there.
I'm still here. Kath, that was fab. Thank you. I'm just gonna. Shall I give you a chance to? Yeah, I can see you at the bottom, but we've still got your shared screen. Do you want to go back to the stop sharing bit?
I don't quite know how to, because it's removed the sharing tag from my Teams screen. I'm just having a look at the other, but it isn't. How about if I do that?
Yay, we've got
Yay, okay, I've just switched the PowerPoints off. See, turn it off and turn it on again.
There's nothing more complicated to IT than that, is there? Really? Jackie, a lot of your questions have been answered, but you ask who's the best person to have the conversation, and you kind of started talking about GPs being the ones that should do that because they know what services are available. But a lot of the time, kind of the idea of the GP is actually quite different. So, can you just unpack that a bit more about who generally?
Yeah, I think I think a primary
Right, let's
care.
rinse you and you can
So,
get...
can everybody please just check you're on mute, because we've got some interesting voices off at the moment.
I think that's Dr. O'Connor. So Alice, can you mute?
No names, no pack drill. So I think that primary care needs to be able to make the plan, but that doesn't mean primary care are saddled with having the whole conversation. The person who starts the conversation is the person who's best placed to have it. And I think we need to start thinking much more broadly than we do about that. This might not be a healthcare person at all. This might be a care home carer. This might be the surgical ward housekeeper. This might be the porter who's taking you down for your 4th scan in a week. We need to start to think about how we think about these conversations, and the conversations themselves, I think, belong to society rather than to health care, and that some healthcare needs to go into it. So at some point, you know, the non-medical people are saying, well, you know, if you're worried about you might end up in hospital, isn't that one of the things you could talk to your doctor about? Isn't that, you know, is there a nurse who looks after you, who visits you from the community nursing base? Do you have a specialist nurse who comes out to look after your lung condition, whatever it is. So this is a series of conversations like a relay, and we're handing the baton over one person to another. And as we're doing that and understanding what's important to the person, we will end up with something that says this person doesn't care where they are as long as their wife is there. So if we've got a no visiting during COVID policy in hospital, this person wants to stay at home. GP needs to now be able to think about what can we offer at home. And that might need to be a GP or a district nurse conversation that says, do you know what, if you needed some treatments that would make you more comfortable that we can't offer at home, are you still saying you want to be here with your wife rather than in hospital? Now, some people at that point would say, well, do you know what? No, at that point, I might change my mind, but I want to try for as long as I can at home. So these are nuanced conversations. They're not, you know, if the SATs drop, admit, are they? They're much more nuanced than that. And that's why a respect form isn't big enough. A respect form is, it says, there's been a conversation, we're scoping where along the sliding scale resuscitation status sits at the moment, or maybe we're not, maybe we've decided. But actually behind the respect form, there's an emergency healthcare plan that says, for the next exacerbation of this person's COPD, for the next overwhelming left ventricular failure of this person with heart failure, for the next crisis of deterioration in this person who's got repeated CVAs, this is what the plan is going to be.
And some of what you articulate is almost us giving people permission to already have the conversation they've had in their head. They're just verbalizing it, but they don't want to let the healthcare professional down by admitting they know it might not work. So we're saying, we know this might not work. Oh, thank God you realise that too. Well, this is where I want to be, and this is what I want to do. So sometimes it's not a surprise, is it?
No, not at all. And I think it's a huge relief to people, isn't it? When we open the box and have a rummage around and they go, oh God, I was waiting for somebody to take the lid off. How nice to see daylight. Yeah.
I'm just interested because we all nick particular really good phrases, and we all get really good practice from certain people who we've watched having that conversation. Who are the people that you've heard a phrase of that's brilliant, or just a way of doing it?
Okay, so my whole script for describing dying is Claude Regnard's, beginning to end, shamelessly, and he knows it. And when I asked him where he'd got it from, because actually I had wondered whether he was trained by Richard Twycross, who was trained by Cicely Saunders. So I wondered whether it was kind of the wisdom coming down the chain. You know, I was really quite excited about that. And Claude was really interesting. He said, you know what? I think that's a very long-winded explanation. But what I was trying to do was explain Elizabeth Kubler-Ross's phrase of not so much a presence of death as an absence of living. And so that whole gentle change, sleepiness, onset of coma, breathing changes was his way of trying to explain how that happened. But what I saw, first time I saw somebody explain what dying's going to look like, and some of you might have read this, sorry, but some of you may not. This lady was frightened of having pain as she died. And he said, oh, come on, we'll go and talk to her. And I was a young registrar. I'd, immediately post membership. It was probably the last time I knew everything when I think about it. So not enough humility, but a huge amount of medical knowledge weighing my brain down. And I thought he was going to go and do a pain consult. And what he did was worries about what dying is going to be like conversation. And as I'm sitting there listening, half of me is thinking, you can't possibly talk about dying to a dying person. That's awful. That'll just completely freak her out. And she clearly wasn't being freaked out. She was sitting up, she was paying attention, she was nodding, she was stroking his hands, she was wanting to know more, she was relaxing as he carried on describing it. So my first prediction was entirely wrong. And the other part of my brain was going back through the, by then probably several hundred deaths that I'd seen, because I'd done a year as an SHO in the Regional Cancer Centre, and I'd chosen all of my medical rotation jobs with oncology in mind. So, I'd seen a lot of dying. And as he's describing the process, I'm thinking, oh God, yeah, of course that's the process. But I'd never seen it because I've been worrying about the blood pressure, the potassium, the oxygen levels. So it had all been isolated things for me, and I'd never stood back and seen the pattern. So hearing him describing the pattern was a game changer for me. And his other lovely expression that I found really helpful is, we're at a crossroads. Now, I really like we're at a crossroads because it tells me there are choices. We're at a place where there are different ways to go, and we could actually have a little look down any of them before we make that decision. So it's a metaphor you can really stretch, but it's not saying it's all over. It's saying it's time to think and it's time to make some decisions.
Because, as someone who does an awful lot of education, I do think there's a role for education. But I do think the stuff that I've learned about how to have these conversations, and the people I've watched who've done it well have watched other people. And it's the watching and being there when it happens that goes, well, okay, that works really well for you, but I could never use that. That's just not me. I wouldn't have that conversation. You think that works for you, and there's no way in any universe that it works at all. But we're not going to have that conversation now. That works really well for you. I'm going to try it. And so one of the questions Jackie's asking is, how do we consistently have this conversation, and how do we make it so that people have it? It's the making thing that worries me. I think some of this is just about people not being afraid to try it and learning the technique, because patients are forgiving. And it's better to have the conversation to not have it at all.
Yeah, I think that's right. I mean, I think there are some things to be really careful about. So one is, it's a lot of information for somebody who's really tired. So the timing of the conversation is quite important. That the message that must not be simply, you will not be awake when you die, because people think that means they'll be asleep. So they then are terrified to sleep. So if you're well enough to feel tired enough to need a nap, you're well enough to wake up from your nap again, is a really useful kind of phrase. And the other thing the thing that you will have observed in Newcastle, because Claude trained the whole consultant cohort for the northeast of England practically, was that we refer to it as the coma talk. It's the script that's used across the healthcare community. So I can have that conversation with the patient and say, that's a lot to take in. So when, Emily visits you next week, who's your Macmillan nurse, check it out with her. Oh, I like Emily. Yeah, no, you like Emily. Okay. So have that conversation with Emily. And I know that Emily is going to use her version of exactly the same story. So it's not scripts. I think if we give people scripts, it sounds scripted. Whereas if we give people principles and concepts, that's how to talk about it. And if you start off the coma talk, and I usually get into it by asking people what they're expecting in the future. And then I ask them if they've thought about what's going to happen at the very end of your life. And they say, oh, I don't want to think about that because it's so terrible. Okay. Well, so we don't have to think about it. But I'm interested that you think it's going to be really terrible, because I've seen it a lot of times and it doesn't look too terrible to me. Could you bear to tell me what you're expecting? Sometimes they can. Or sometimes you can just say, well, it sounds like what you're expecting is way worse than what I'm expecting. Wonder if it would help you if I describe what I've seen so many times. Or if you're very junior, would it help you if I describe what people I've worked with have seen many times? And I promise I'll stop if it gets to a point where it's too much. And I always promise that I'll stop. And nobody has ever stopped me. Nobody has ever stopped me. One patient's wife stopped me and threw me out of the house. But there was somebody in the room who couldn't bear it, and it wasn't the patient.
If you can just write your question for me rather than us having to turn mics on and off, that'd be really helpful. And Jackie, that comment was really moving. Thank you. Jackie's just shared her experience of what happened with her mum, and that she said it was as perfect as it could be. We avoided hospitals, and which is what she would have wanted. But actually saying that she felt a huge level of responsibility for trying to get it right for her mum. I just want to bring in something that Kath Molyneux from the Community Trust has written about. Sometimes the patient wants to have the conversation, but the family are kind of gathered around the bed like bouncers trying to stop you. And we've often had those conversations, haven't we, on the doorstep of, you mustn't tell mum how ill she is, and then you wander in and then mum says, how ill am I? Any advice and tips for kind of how you deal with that one?
Oh, it's a corker, isn't it? And it happens so often. And there's a story about this in the book where the husband let me into the house and immediately took me into the front room with this big stage whisper of, you mustn't tell her, it'd kill her. And it's all love, isn't it? So we don't want to fight with it. So what I usually do is say, right, I need to have a conversation with this person, and it would be really, really lovely if one of you would stay here, which is code for the rest of you leave while we have this conversation. Okay, but I really like somebody to stay here just to be her friend and supporter while we have this conversation, and just so you check that I don't say anything that you're hoping I'm not going to say. And then we help the person to ask us the question. And if they don't ask it, then we can't have the conversation. But we can offer it. And I think one of the things that we think is that we need to give people a really good talking to. And in fact, it's all about listening, isn't it? Okay, so now we're sat down and it's just the three of us. I can imagine there's all sorts of things on your mind that you might like to check out. And I've got a whole half hour that's just for you. What do you want to ask me? Are there any things that you're worried about? Do you have a best hope or a worst dread that we should really be thinking about? So I haven't said anything naughty there, have I? I haven't said anything that the family could shout at me for saying, but the door is open.
And yet we're not very good on nuance in healthcare. We seem to go, I'm not going to talk about anything, or I'm going to talk about too much. Whereas sometimes it's as much information as the patient wants at that
Absolutely.
point, isn't it?
Yeah, absolutely.
I would say this, but I think I've learned a lot through general practice, which is it's quite a physician-y hospital thing, given that often you'll only see the patient at one point. But there feels like there's a pressure. I have to have all of the conversation at this point and go through the list so that it's all covered. Whereas the GP thing is more about triage. You go, okay, what do we need to do today? And a Kath Mannix phrase is, what do we need to talk about today? So the first thing that you do with a patient is you deal with their priority. And we go in thinking the first thing they want to sort out is their pain. But actually the first thing they want to deal with is what's going to happen to the dog when I'm dead.
Yeah.
But because we're going up with our agenda, we miss. So that's my Catholic thing. You start with what do we need to deal with today, and then okay, once we've dealt with what's right for you, here's what I'm worried about. But not feeling like you have to cover it all.
Absolutely right. So there's two things about that. One is using time as a tool, which is a GP phrase that I got from our friend Lindsay Crack. So we can do a bit today, and then we can just kind of step back a bit and see how that goes, whether that's a therapeutic intervention or whether it's conversation. And then the other thing is to see ourselves as parts of a team. This is not a conversation with me, it's a conversation with us. Okay, so thanks for telling me that you really worried about the dog when you've died. I'm sorry you're worrying about that. And actually, I don't know a lot about that either, but I'm going to find somebody who can give us some advice about that. But what's interesting for me is I didn't know you were even thinking about dying. So I'm going to find someone who'll give us advice about the dog. Are there any other things that you're worried about dying that we should also be talking about? Okay, so thank you for telling me about that as well. I can see you're really tired now, and there might be some other things. Will you write them down? And then when your district nurse comes tomorrow to change the syringe driver, will you pick this up? And I'll try and phone him today, but in case I can't catch him, will you pick it up with him? And so what we're doing is we're saying I'm part of a team, that I know the name of your district nurse, because if you're part of the community palliative care team, you do know the name of the district nurse, you know their base and you know how to find them. Or they're in your outpatient clinic, and say like, okay, so thanks for telling me that. You've seen what the waiting room is like. I'm sorry you had to wait to get in. we've managed to give you a few extra minutes here, and I'm glad that we could do that. And I wish I could give you another half hour, but I really can't. So can you start to write some things down? Can I give you a ring? Can our nurse specialist give you a ring? Can I ask your doctor to call you? Let's place ourselves in a team instead of thinking that it's me with a list. And unless they've said it to me, I can't believe that it's right.
And Sarah has just written that relatives are often surprised at how calm and welcoming of the conversation the patient is, and they often learn a lot from their relatives' own words. So that it's really powerful having the person there to hear what Mum said. So thank you, Sarah. I just want to talk a little bit like Karen said. Karen Stringer, again from the Shropshire Community Trust, was asking your thoughts on children being with relatives when they're dying.
Hi, Karen. I think I know you from Twitter. And funnily enough, I've posted a whole string on that today. So I think we should be giving children choices. I think we should be giving children information and support, and then saying, okay, so it's up to you. So Grandad is getting very close to dying now. Okay, dying is the word that we're talking about here. Let's use the real words. What would be really nice for that child is that talking about dying around Grandad isn't the first time we've talked about dying, because we've looked at dead beetles and dead birds and dead pets and lots of other dead things. So we've got a vocabulary and an understanding about dying, death, lack of function, permanence, those sorts of things. And it partly depends on the age of the child, of course. But now we're talking about Grandad dying. His body is really, really tired. That's why he keeps falling asleep all the time. And we're going to be visiting him. And yeah, I am sad that Grandad is dying. Of course I'm sad. So sometimes I might cry. Sometimes I might need a cuddle. That's okay. You might feel sad too. And if you feel sad and you want to cry and you want to have a cuddle, that's okay. You just tell me. And what we'll do is we'll go in and we'll just say hello to Grandad, and then it's up to you. You've got your book, you've got your Game Boy, you can sit in the other room, you do what you want to do. So now we're in the room and there's Grandad and he's making, he's chain stoking. What do you think about Grandad's funny breathing then? So this is what happens when people are dying, that they make this, they're breathing because they're so relaxed. They make a funny snoring noise like that. He's pretty noisy, isn't he? So do you want to climb up on there, give him a bit of a cuddle, give him a whisper in his ear? And then it's up to you. You can sit over there with your Game Boy and get your juice out, or you can go and sit in the other room. Oh, you don't want to come in? Well, that's okay. You just sit in there, and I'll be in here with Grandad, and you can come and say hello if you want to, or you can stay outside. It's absolutely up to you. So I think it's all about giving them information, giving them choices, and then modeling. Okay, this is what happens when people die. We look after them, we visit them, we talk about things that are important, we tell them we love them, we feel sad, sometimes we cry. This is all okay. We can be sad and okay at the same time. Let's have emotionally literate kids by modeling it.
And also sometimes it's not so much the children can't cope with it, it's the parents, I can't cope with the children knowing it's more about me. And actually kids are just so much more resilient than adults sometimes.
Yeah, absolutely are. But the other thing to think about, of course, is if the person who's dying is your close relative, if it's your spouse, if it's the children's co-parent, if it's the grandparent that they're very close to, then you're doing your journey at the same time here. And so they might need other support, because kids are very good at looking after us and not letting us see their distress. So is there another person that you really trust? Is it a teacher? Is it, is there a friend that they go for sleepovers so they know the mum and dad at that house quite well? Who else can you recruit into your team? Make sure the school know, so that if behaviour or performance in school changes, school manages that with compassion rather than being cross, and that they understand what's going on and they can report back to you, because you need to know to be able to parent through those changes that are manifesting at school. Sad children might need a day off school. Children might need to choose whether to go to school or not on the day that you're expecting the very end of somebody's life to happen. They might need a heads up before they go to school. You might decide not to do that. So I've had lots of responses to having said something about this on Twitter this morning in response to a question from somebody. Lots of people talking about children between the ages of 9 and up to late teens, and how much they wanted more to be there and see what happened and be involved than they wanted to be excluded or protected.
And yet, Mark's made a point that sometimes kids don't really cope with metaphors or euphemisms. So dressing was, but actually, I take it further. I actually don't think people do in these circumstances. I mean, that we think that we're saying something like "there's a shadow on the lung," when actually, what does a shadow on the lung? To a doctor or a healthcare professional, that means you've got cancer. But to someone who's arriving at hospital, that means nothing. As
Yeah.
a certain consultant used to shout at us if we didn't use the word "they've died." Can't think who that might be.
I don't know.
Because we'd say, well, we've lost them. And we actually did have someone who was really distressed because they thought that we had literally lost their relative when actually we were saying they died.
Yeah.
And if you don't, I mean, obviously there's a way to say it, but if you don't say that, it doesn't make any sense, does it?
I absolutely agree with you that it's the compassion that we're speaking with and not the words that we use that people hear. And bereaved people, dying people, the families of dying people, they get to choose their language. We're not the thought police here. It's really hard to use the D words when it's your person who's died. And I was really surprised how my best friend died actually 10 years ago this week. And I found it quite hard to use D words about her for probably 2 or 3 months, despite the fact that I threatened you with horrible violence if you didn't use D words when you were working with me. So, the people who are emotionally enmeshed get to choose their language. But we can say, I am so sorry to hear that your father is dying. I'm going to do my very best to make sure that as your mum is dying, she's as comfortable as she can possibly be. And we're saying something that's much more than the dying there. There's a message there that's a person-to-person message.
There's quite a lot of chat about how we make sure that the message gets transmitted more effectively, because the bit of paper goes missing or someone's written the respect form, it doesn't get moved on. As someone who's now got more of a national perspective of this, have you seen places where that's working really well? What do you think about electronic stuff? Or is it just something that we all need as a country to kind of, or countries, sorry, to kind of get our heads around how we do that properly?
So Scotland's doing really, really well. And Scotland has a single electronic record, and they are able to upload additional stuff onto it. And they also doing better than the other kingdoms, principalities and provinces in terms of a percentage of people with some kind of advanced care planning having taken place. There are great claims made for a variety of electronic platforms, and then you find other users who say, oh, we tried that, didn't work for us. So part of the difficulty we've got is that if we invent them region by region, which is what the government is asking us to do, then they're never going to be able to talk to each other when they need to. So my advanced care plan from Northumberland isn't going to come on holidays with me to Shropshire, is it? So that's a difficulty. So I think everybody is still struggling with it, and it's costing lots and lots of money. That's duplication of effort and duplication of advisors who are being paid the same money by different organisations to give the same advice. I think it's iniquitous. I think it needs a national solution, and I'm usually very localist, but actually this needs to work for all of us wherever we are. And I haven't seen it working wonderfully anyway yet.
Caitlin Willis, I don't know who she is.
Whoever she is.
Really valid question. Well, you raised the point that death in the way it's kind of portrayed in the media isn't an accurate reflection. Do you think we're kind of doomed to have that just because the sensation is always going to sell, always going to make a better story? Or do you think there are better ways to have a more realistic narrative? And I guess I'm interested in what's your story been about being the person who says this is what death's like? Because I know, as RSC lovers, we're very jealous of the fact that you've got your name on an RSC program. You owe me a fiver for putting that drop in there for you. So how has the narrative that you've been kind of saying been picked up by people, or are they still stuck on the I don't know, Dot Cotton and whatever her name is? She's that pug dog, didn't she? That was kind of one of the first sensational things.
Yeah, great question, Caitlin. And the answer is that I think the arts are interested in exploring ordinary dying, is what I'm calling it. So the RSC wanted to get their dying right in their play, Cuneni and the King. I'm working with another playwright at the moment about something, and I've worked with a couple of other people over the last couple of years. But I had misunderstood about death in drama, and I spoke to somebody who is a television writer, who some of you may see in her other shows and things, called Carrie Lloyd. And Carrie was interesting. She said, yeah, but the problem is, of course, that when we're writing a death scene, we're not writing about the dying person. We're writing about the people around the bed, and the death is a situation that engineers things happening for the other people. So it's a plot device. We're not at all interested in getting the dying details right because it's boring. And yet Coronation Street won awards for their Sinead or Siobhan plot line, because the nation was weeping. And I had a whole evening of people texting me, calling me, things pinging into my phone saying, did you write this script? No, I didn't. I had nothing to do with it. But what they did was they portrayed ordinary dying. They portrayed the sorts of conversations people have around deathbed. They were advised, probably by the people at the Christie, about how to manage it. But what they did was very faithful to what we actually see happening around deathbeds. And it was intensely moving and very, very powerful. So it is worth TV people thinking about it. There have been deaths portrayed as part of Call the Midwife. And in fact, Jennifer Worth, having written her midwifery books, then went on to become a palliative care nurse. So there's a really lovely rounding of that story coming out there. But the discussions of dying and death in Call the Midwife are always very good. I'd love Heidi Thomas to serialize my book.
Well, your book's been translated into Chinese. I saw the other day. Is that right?
It has. I don't know what people in China are going to make of, like life, end of life in the UK. But yes, it's in 12 or 13 languages now.
That's amazing. I mean, you mustn't have, when you were just sitting down to type the stories of, because I know you made a journal of these people, didn't you? And of people who'd stayed with you during your career. And then you got in touch with them and asked permission just to write their stories. You mustn't have had any idea that it was going to take off the way that it has. Or did you? Do you know what? I want to be going to China. I want to go to the RSC.
I wouldn't have touched it if I thought this was going to happen, if I'm really honest. It's been a little bit terrifying. It's been amazing, but a bit overwhelming. So I used to keep a journal for people who I couldn't get out of my head, so I'd write them out of my head, because people get supervision these days, but that didn't used to happen in the olden days. So I think that goes back to things that happened to me when I was a medical student, and they're not all sad things either. I mean, like the first baby that I delivered is in it as well. So it just was a way of kind of making sense of things and putting them somewhere safe. It's all on paper. It's all dated. It's all very faded. I may have to photocopy it soon, actually, so it doesn't disappear. And it was a record for me. I haven't kept them all even. I never anticipated I would do something else with them. But then when I decided I was going to try to do something about, how did my Nana understand about dying? My Nana understood about dying by having been at deathbeds. What can we do about the public understanding of dying? We can take them to deathbeds. So that's what the book is doing. The book is saying, come with me and let's go visit these people and see what's going on. And it was written entirely with the public in mind. So the fact that it's been adopted so widely by healthcare schools and healthcare professionals has amazed me. I didn't see that coming. But what I'm trying to do is enable people to think these are conversations that I could have with that GP that I know very well, with my district nurse, with my with the heart failure nurse who visits me. I know that person well enough that I could have a conversation like this with them.
James just asked a kind of a bit of a local question. I just want to give a quick 30-second answer. Basically saying that Shropshire's very disjointed with our advanced care planning. Yes, our first place was to make sure that the respect document was the same, and actually that's worked. And now people are saying that respect hasn't got a little bit like you were saying. It's not a ceiling of care document. It's not an emergency care plan. We've done a proof of concept. We don't do pilots anymore. We do proof of concepts. Apparently, I've been told, to just try and nick from what the children's emergency care plans and try and use that for adults with a little bit more about what does this future look like for you. And we're waiting to get that approval before we roll that across the county. So we're going to hopefully have a standard advanced care plan document, which I think will go some way. Also, I think we should just trust patients the same way that, you know, people generally don't lose their obstetric and kind of child health record. As long if you said this is yours to hand over to someone, and another Kath raises, this is the document to stop the ambulance coming, to protect you from the ambulance coming. If we give people the responsibility from it, it's most likely to get kind of missed and lost. Kath, we can't go with it. You've said the D word, but there is the C COVID word. You've kind of made. How do you think has death changed? I mean, as a palliative care physician, I suddenly became very popular, and suddenly people realised what I did, and I've been incredibly busy over the past year. Any perspectives on society's view on what death is, how death has changed within the UK, and maybe what we as Shropshire healthcare community and healthcare can pick up on and do as good practice?
Yeah, I think it's been really interesting, hasn't it? Interesting and awful and exhausting for people. And it's been very interesting and difficult to be watching from afar. I came back into work for the first surge locally, and they gave me staff support and communication skills training as a job rather than bedside care. And there was a bit of me that was sad about that, and a bit of me that was actually quite relieved about that, because I have had a mum who was shielding, and I would have been her carer had she become sick. So what I heard from hospital staff was just the sadness of the absence of family, the absence of those loving messages, and the enormous weight, which they saw as a privilege, but it was a heavy privilege, of being the person who carried those messages from one phone to a person and then back from the person to the phone, because it's very difficult to have any kind of conversation in the presence of high flow oxygen. It just is too noisy. So I think one of the things that's happened in hospital care is that staff have seen dying more, and we've had people dying not of COVID, dying alone with staff in attendance instead of families. We've had people dying of COVID doing a relatively ordinary dying trajectory. And then we've had that strange COVID specific dying of being unexpectedly awake despite quite low SATs until very, very late in the process, which was really, really disconcerting for people to be discussing that. You know, the person's watching, sometimes their SAT's dropping and knows what's going on, and that's been quite traumatizing for people. But it means that we now have many, many more healthcare professionals who've been alongside dying people, who've had those moments of tenderness, who might feel less anxious about what would happen if I have to talk about tender things, because I think we are anxious about being tender and vulnerable beside people, and what if I get upset, and all of this. What I've discovered in 30 years of weeping at people's bedsides because I've got taps behind my eyes is nobody's bothered. As long as you're not kind of howling and they're having to look after you, it's okay, you just get on with it. In the community, I think we've had a different and much more difficult situation where the number of people who chose to stay at home or could not get into hospital because of what was happening was overwhelming also for primary care services. And I want to pay huge respect to primary care services and the work that was going on there. I see we've got a note from somebody saying mention school nursing. My daughter is a school nurse, so of course I will mention school nursing, because otherwise I will be shot. So the amount of work that's been going on behind the scenes in primary care and in community settings, including school nursing, to actually offer information and support and enable people to be able to cope with very difficult things, and the difficulty of getting supplies into people's homes, so that at the point that they needed a syringe driver, there was a syringe driver and a person who could actually set it up, for example. So I think it's really difficult if we set up people to have expectations that we're going to deliver on symptom management, and then there's a 3-hour wait for somebody to manage the symptoms or find the kit or whatever. And we're all geared up for protection. We're all geared up for not losing the drugs and not losing the syringe driver, instead of the stuff being there and it's easy and we make it happen. And it's all about budgets. And to some extent, it has to be about budgets, but it shouldn't only be about budgets. So I think COVID has shown everybody that we're mortal. It's shown everybody that anybody can die. And it's given us an experience of bedside care of dying people that, when people have recovered, and I think recovery is going to take quite a long time, will be a bedrock of experience that we're going to be able to call on in the future.
And I think as a palliative care doctor, you suddenly get aware of how you give advice to people and sometimes you have no idea what you're talking about. Because getting people to deal with uncertainty, then throwing me into the uncertainty of COVID or what's going to happen. Yeah, I'm telling people how they deal with this uncertainty, and now I'm living it. So maybe now I've got a little bit more understanding of how uncertain it is. Of, well, what do you mean about I've got a scan in 3 months? What's that? What's going to happen? How you live with that? How you pace yourself? And also, as someone who managed to catch COVID 4 days after having the vaccine, that's unfair. I now get a little bit more about what fatigue means. And fatigue is not tiredness.
Yeah.
And also quite scary that, 28 years I've been in practice. I think the cancer care has gone back to 28 years, not because of people have got rubbish, just because of late presentations. And I'm starting to see things that I saw when I was a houseman in the day when they were. People just turning up with horrible cancers, just diagnosed far too late. And I think we're going to see that for another year or two at least, aren't we?
I think we are. I think it's going to be a long tail of things that were diagnosed late or were diagnosed in a time. The worst thing I think for people is to know they've had their diagnosis and now they can't get their treatment for whatever it was. And also we're going to have a long, long bereavement tail, because one of the ways we deal with grief is by knowing the story, by being at the bedside or talking to somebody who was at the bedside. And we listen to people, don't we, when we're at hospice, when we're doing community visits, when people are dying in hospital, we listen to the families doing their handover as somebody arrives. So the last thing Dad ate was, and it was at X o'clock, and the last words he said were, and he didn't open his eyes, but he waved his fingers when Mum was going home to have a sleep. Okay, so now that gets picked up, and the next shift will hand on that plus the next thing, and gradually we build the story until we get to Dad's last breath. And now suddenly that was switched off, that wasn't available. What a lot of hospitals have been doing is using the ICU diaries that ICU nurses write for patients, and Michael Rosen has spoken really movingly about his ICU diary since he's got home from hospital. And they've been using them in the COVID wards as well. So there is a record of what's happened shift by shift, and who said what and who phoned and whether you finished your cup of tea and things like that. I don't know how staff have found time to do that. And I am in awe of what people have achieved over this last 14 months. It's just been astonishing.
So I want to kind of finish on a positive note and a challenge, I guess. If you were going to tell us as the healthcare community of Shropshire, Telford and Wrekin about what we could do to make dying better for the people that we're responsible, that we live with, that we look after, What few things would you want us, if you came back in a year's time, please come back in a year's time, what would you want to see that we were getting better at doing?
I have the sense that there's a lot of very good stuff going on locally already. And I think that one of the things that I get a sense of about your healthcare community is that it sees itself as a healthcare community, and that people talk to each other, and that people are proud of dying well, and that the trust has a really charismatic end of life care lead who's giving people feedback and ensuring that they do know that they're doing it well. So I think that one of the things, like a lot of places will have morbidity and mortality reviews, we really ought to be reviewing every death. We really ought to be able to look at each death and say, what was the last 100 days like for this person? And there's a really lovely video that you can all Google afterwards called The Last 1,000 Days, which is all about exactly this. If you knew you had 1,000 days left to live, how would you spend them? And you'd spend the fewest days possible in hospital, and you spend the most days possible possibly not in a place, but with particular people. Or for some people, it's a particular pastime. They would do more fishing. They would finish writing their book. They'd paint. They'd visit their grandchildren. They'd swim to Australia. I don't know. So why can we not start to see everybody as a person who's potentially in their last 1,000 days? So every touch that we make in the medical system is about empowering people to be their best self, their best version, in the place that they want to be, with the least possible symptoms from whatever illnesses they're dealing with. And why can we not start to see each other as mutually responsible for that? So if I don't have time today, you won't think, God, she ducked that. You'll think, okay, she started it and I will pick it up. And we will be responsible to and for each other for that.
It's interesting. I was giving, as everything is at the minute, online lectures, and given that I'm supposed to know something about long dead philosophers, I tried to find a really fascinating quote. So I started with Lord of the Rings, and then saw there was this amazing quote which said, "The time is coming when we must choose between what is easy and what is hard." Isn't that amazing? Isn't that describing where we've been and actually where we're going? That we've got an opportunity now to do what's right. And actually, do you know what? Sometimes what's right is hard. So having those conversations is hard. I found that actually a quote from Harry Potter. So I can't quote from big philosophers. I can quote from J.K. Rowling. But that phrase has stayed with me, of making the choice between what's easy and what's hard. So I can go in and I can see this patient and it's easy, and I just throw painkillers at them and walk away. Or I can actually go in and actually address this. And that might take a bit of time, but actually the hard thing is the right thing to do.
Yeah.
Maybe that's part of what he's saying, is just don't forget that people are people in the middle of being patients.
Yeah, and that all of their life they are people. And so if you were to put a deathbed center stage and then manage the stage around it, we wouldn't even be on the stage. We would be in the wings, in the kitchen, making tea, chucking the syringe driver. We might have a bit part where we come in to do something and then we leave again, because dying is not about us. Our job is to make it as easy as it can be for the people that it's happening to and the people who are important to them, and for us to not be in the way.
Fab. I'm going to let you go and enjoy the rest of you. You have been so kind in sparing the time and giving us so much to think about. And as always, completely inspirational. Everybody, if you have not read With the End in Mind, you absolutely need to. And I hope, having heard Kath for the past kind of couple of hours, that it's really kind of inspired you to want to do it. And maybe, I know a lot of people over COVID have developed book clubs and started doing book clubs. I guess one of the things I want to put down as a challenge: why don't you have Kath's book as a book club book? It's a Sunday Times bestseller, and a really good way of getting conversations with people in a book that you know is really, really well written. So So, Kath, thank you, and as always, you're amazing, and thank you so much for what you've done for us as a community in Shropshire, but for the UK. You've made conversations easier because we've got a really good book to point to. So, thank you.
Thank you. Thank you all. Thanks for so many people for turning up. That's fantastic. And good luck to you all, because I know it's really hard and I know everybody's really, really tired. Take care of yourselves. And thank you for having me.
Thank you.
So, Jill, someone's asked a question that this has been recorded, hasn't it? So we're going to make available for people to have a look.
Yeah, no, it's all been recorded, so I'll finish the recording, tidy it all up, and we can save it. But I will. Let me stop recording.